Hello and welcome back to my YouTube channel. In this video, we will have a comprehensive review about the histopathology of the different non-neoplastic GI polyps. Now, why have I chosen this topic? Because GI polyps is one of the most common biopsy specimens that every pathologist encounters in their day-to-day practice. It is very important to understand and differentiate non-neoplastic versus neoplastic GI polyps in order to avoid overdiagnosis or underdiagnosis of any specimen. So let's begin. Now, what are the different learning points that we'll cover in this video? Firstly, let us understand what is a polyp. So polyp by definition in pathology is any abnormal growth or mass. And this abnormal growth or mass which will always protrude from a mucous membrane or a lining. So it will always protrude from a mucous membrane or lining. Polyps are always seen in organs like colon. It is seen in stomach. It is seen in uterus, etc. Now this polyp, it is very important to identify whether it is non-neoplastic or neoplastic. Why? Because neoplastic polyps are always having a higher cancerous risk. So that comes to the next learning point. We have to classify the different non-neoplastic GI polyps because even these non-neoplastic GI polyps carry different prognosis which will determine the cancerous risk. Then we also have to discuss the prognosis of these polyps in a follow-up. So, how do you classify the different GI polyps? So, in order to make it a little bit concise, I have classified it as type and then examples of these kind of non-neoplastic GI polyps. So, firstly, you have the inflammatory or the pseudopolyps. Now, in that, you can find these inflammatory or pseudopolyps in conditions like ulcerative colitis, Crohn's disease or inflammatory fibroid polyp. You next have the hamartomatous polyps. Now, hamartomatous polyps can be seen in Peutz-Jeghers polyp, juvenile polyps, P10 or Cowden syndrome polyps, Cronkite Canada polyps. You then have the hyperplastic polyps which are usually found in the microvesicular hyperplastic polyps or the goblet cell rich polyps. Isn't this classification a little bit too complex? I will simplify it for you in the next few slides. We'll now start with the inflammatory polyps. So, inflammatory polyps is a kind of a generic term which is used to describe any polyp which has a mixture of epithelial, stromal cells as well as inflammatory cells. As discussed before, these are found in diseases like Crohn's disease and ulcerative colitis. It is found as ischemic colitis. It is also found in anastomosis and any sort of an infection. Let us now understand this video. Now in this video we can see that the normal colonic mucosa is in a sort of a polypoid configuration. There is also under low power we can see a lot of surface erosion which is usually present. So over here you can see that there is a lot of surface erosion which is present. Now, as you go into the higher power, you can see that the lamina propria has a lot of inflammatory infiltrate, mostly composed of lymphocytes and plasma cell, along with granulation tissue. Some of the colonic glands are also expanded. That is, these crypts, they are appearing a little bit dilated. So here you have dilated crypts. You have increased inflammation in the lamina propria and you also have granulation tissue. So like I said, there is a lot of dilated crypts. I will show you in the further slides what are the other findings that you can see in an inflammatory polyp. So the other findings as highlighted here is cryptitis. So cryptitis can also be usually seen, and as I had highlighted in the previous slide, there is surface erosion and there are dilated crypts. We now move on to the hamartomatous polyps. Amongst the hamartomatous polyps, the most characteristic polyp which is most commonly seen is the Peutz-Jeghers polyp. So Peutz-Jeghers polyp is a hamartomatous polyp which is associated with the Peutz-Jeghers syndrome. So in Peutz-Jeghers syndrome, the most characteristic mutations which are present are the STK11 mutation. Now let us have a look at this slide. So in this slide you have a small bowel mucosa which is in a polypoidal configuration. Now in this you can see there is a very distinct papillary villus architecture. As you go to the higher power, you can see that these epithelium, which you can see, they are in a bland configuration. That means they have no atypia which is present, and you can see here that all these glands appear dilated. So you have two very important features. One is glandular dilatation which is present, and these epithelium, they do not show any cytological atypia. You can also see as you go further that there is arborization of the smooth muscle fibers. So the smooth muscle fibers, they form bundles and they show arborization. Or arborization of smooth muscle bundles. There is also interspersed blood vessels which are seen. So, to summarize, there is papillary villus architecture of the small bowel glands. It is in a polypoid form, and there is arborization of the smooth muscle as you can see here. There is also some sort of a erosion and reactive epithelial changes in some of the polyps. After understanding about the Peutz-Jeghers polyp, we'll move on to the next polyp, which is the juvenile polyp. So, juvenile polyp is associated with the juvenile polyposis syndrome. In this, there is hyperplastic foveolar epithelium, excessive edematous lamina propria with cystically dilated mucin-filled glands. Juvenile polyps typically occur in the antrum of the stomach. In order to understand the features of juvenile polyp better, let us have a look at this slide review. As you can see here, this is a biopsy of a stomach mucosa in a polypoidal configuration. There is hyperplasia of the foveolar epithelium. You can also see that there are cystically dilated mucin-filled glands over here. As you go further into the higher power, you can also see that there is a lot of inflammation in the stroma. So over here also you can see the hyperplastic epithelium, and over here you can see the inflamed stroma. Two variants of juvenile polyp are usually present. One is a classic variant. Now in classic variant, the cryptostroma ratio is usually less than 1 and it is associated with the BMPR1A mutations. In classic variant, it is usually a stromal dominant variant. So this classic variant is stromal dominant. What are the features here? You have the hyperplastic foveolar epithelium. There is granulation tissue, mucin filled crypts as we also saw before, and there is inflamed stroma. The next is the epithelial dominant variant, wherein the cryptostroma ratio is more than 1 and this is associated with SMAD4 mutation. Over here you can see that the polyp is in a villous architecture. There are again mucin filled crypts, but there is minimal stroma as compared to the classic variant. Now juvenile polyps also display dysplasia. In low grade dysplasia, as you can see here, there is elongated overlapping nuclei, but the polarity of the cells are maintained. But in high grade dysplasia, it is in a very complex cytological architecture. There is usually cribriform and back-to-back glands. As you can see here, these glands are back-to-back. There is no space between them. They are in a cribriform architecture and there is round nuclei and frequent loss of polarity. So as you can see here, there is no polarity which is present. The next form of polyps that we are discussing, which is also a form of hamartomatous polyps, is the Cronkite Canada polyps. Cronkite Canada polyps are rare and they are associated with the non-hereditary polyposis syndrome. There are usually multiple polyps and cystically dilated glands, as you can see here. So here there are cystically dilated glands. There is also an edematous or an expanded lamina propria. So as you can see here, these lamina propria, they are usually expanded. There are also mononuclear cells as well as eosinophils. The next form of polyps that we will discuss is the hyperplastic polyp. Now hyperplastic polyp is a very common type of polyp which is seen in the colon as well as the rectum. So there is usually a serrated architecture with a sawtooth appearance and the serrations are limited to the upper half of the crypts. This is very important to note. The two types of polyps are goblet cell rich variant as well as the microvesicular variant. We'll now start with the microvesicular hyperplastic polyp. This is a non-dysplastic polyp and as we discussed before, the serrations are only limited to the upper half of the crypts. So this is a more common variant. Now in microvesicular variant, basically there are epithelial cells and here you have small mucin vacuoles. So there is also surface tufting and this is the sawtoothing that we are talking about. Now goblet cell rich variant is a much less common variant and this usually has prominent goblet cells. So as you can see here, these goblet cells are very prominent. So this was a comprehensive review about the different non-neoplastic GI polyps. I hope you enjoyed this video. If you did, please like, share and subscribe to my YouTube channel and comments. Healthy discussions are always welcome in the comment section below as always. Thank you and see you in the next video.